Good afternoon and welcome to today's event. Thank you all for joining us. On behalf of the Sidney to Haan Research Centre for Arts and Health, we're excited to launch our new research webinar series entitled Health Through Arts, Connecting People and Communities. We welcome you today to our first live event of the series, Applied Theatre in Paediatrics. Can participatory performance mitigate educational, emotional and social consequences of missing out school during hospitalisation? This afternoon's session will be made up of 3 sections. During the first 20 minutes, Professor Persephone Sextou, Professor of Applied Theatre for Health and Wellbeing and Centre Director of the Sidney to Haan Research Centre, will present findings from her paper. Following her presentation, Persephone will lead a 20-minute discussion between herself and our leading guest expert, Associate Professor Sidney O'Donnell from the University of Utah, USA, who we are honoured is able to join us today. The final 20 minutes will take the form of a Q&A, during which Persephone and Sidney will have the opportunity to answer some of your questions. Please submit any questions via the Q&A box while the event is in progress, and we will endeavour to review and publish as many questions as possible in the Q&A box for all attendees to read. A representative selection will then be put forward to Persephone and Sidney. When submitting a question, please remember to always use polite and appropriate language in line with the university's digital code of conduct. And lastly, if you require live captions for this event, please click the closed captioning subtitles CC button in the bottom right-hand corner of your screen to enable this function. I'm delighted to now hand over to Persephone for what I'm sure will be a very interesting session. Thank you.
Good afternoon. And welcome to the first of the Sidney to Haan Research Centre's webinar series. I'm delighted I'm here with you today to share my paper, Applied Theatre in Paediatrics. I would like to say a few things about my philosophy when I do research in the community. To me, it's important to experience an all-inclusive sense of happiness in terms of intellectual and human goodness, rooted in Aristotle's eudaimonia and theory of happiness. In applied theatre in particular, we accept the influence of others on us and vice versa and involve them in our work, promoting co-production, working closely with them, attending to their needs and their interests, and also promoting knowledge exchange of experiences through theatre with a caring, empathetic and compassionate interest. And that is rooted in my appreciation of Heraclitus' theory of change and how we need to accept illness really as another way of life, another aspect of life and a new identity. So by employing these theories and this philosophy in my work, I design my research, I pilot it with children in schools and hospitals and hospices, and then I use their reflections to recraft it, to reproduce it, to re-rehearse it, and come up with something that is more bespoke to their needs, their abilities and their interests. And then I take it back to them as an appreciation, a recognition of their involvement and their contribution to my research. What is participatory theatre for children in hospital? In simple words, and I'm using a clinical term here, is an antidote to clinical stress. Is a medium that aims to reduce the influences of toxins, like clinical stressors and negative emotions in the child, and normalize their hospital experience, offer them personal attention, entertainment, care, and compassion, and create opportunities for them to communicate how they feel within the protection of the fictional conditions of the story we show to them. My presentation at a glance. My aim is to explore the improvement of children's hospital experience and their engagement with school learning during illness through applied theatre. I used a mixed qualitative approach. By interview, I collected data that was analysed using thematic analyses. Some stories were collected, as well as the views and perceptions of hospital teachers who worked with children on the wards. The main conclusions of my work are 5, but here in this abstract, I'm only mentioning 3 regarding the impact of the work on the children's hospital tuition and their engagement with learning, how applied theatre can actually improve their management of emotions and help children relax and experience an easier way of coping with anxiety before and after their operations, and also the ways they are relaxing and improving their day-to-day experience in hospital. The focus of my presentation today is the Bird Island Bedside Theatre project. And the question I asked was, can participatory performance mitigate educational, emotional and social consequences of missing out school during hospitalization? And here you can see Joe, one of the puppets that traveled on hospital wards over the years. My methodology. In general, I evaluated this project from many different perspectives. I collected evidence directly from children, from actors and storytellers and puppeteers, from hospital teachers and from families and carers. This paper focuses on evidence I collected from hospital teachers, who are in a unique expert position in relation to children's experience of play and learning during their hospitalization. I interviewed 10 hospital teachers. I used semi-structured face-to-face interviews. That was before COVID. And I analyzed the data by the inductive thematic analysis technique. I also kept reflective journals myself. At the majority of the performances that took place in the hospital, for those performances, I was there. I was watching from a distance. Sometimes I was outside a cubicle or outside a little room where the children and the performers and the teachers were, but I could still see and sense and keep notes. And I used those notes in a dialogue with the findings from the teachers' interviews.
Sorry to interrupt, Persephone. Can you forward your slides, please? We can only see the first introduction page of your slide. Sorry to interrupt.
Oh. Can you see it now?
Yes, but if you go into slideshow mode, then I think Lars will be able to help you with it.
That's what I did. So apologies if there were any problems with my slides. I hope that now you can see them. You've been very patient with me, and thank you. And here is the abstract at a glance. My puppet Joe, my methodology, and the where, the when, the who and how. So the Bird Island took place in hospitals, at Birmingham Children's Hospital mainly, at the heart of Birmingham City in England, and also at Hartlett's Hospital at the Heart of England Foundation Trust, NHS Trust. I worked with a fabulous team of hospital teachers at the James Brindley School at Birmingham Children's Hospital. The project took place from October 2016 to September 2019. Performances happened from 10 o'clock in the morning until 3 o'clock in the afternoon with a break in between. We visited the hospital every other week. Sometimes we performed to the same children if they were long-term patients. So there were occasions that we saw the same kids for 3 or 4 times in the period of 1 academic year. Children ranged from 4 to 8 years old, unless the parents and the child wanted to have us bedside. There were cases where children were a little bit younger, like let's say 3 years old, or a little bit older, up to 9 or 10 years old. We performed in Paediatrics, cardiac, oncology, hemoglobin pathology, dialysis, neurosurgery, Paediatrics intensive care unit, and complex care wards. Part of the methodology was Lolly's story, The Rough Collie and the Magic Kiss. It's a story to tell children when they are undergoing treatment or when they are poorly. It's a real incident, that story. It happened to me when I was young, and I was studying for my A-levels. I was at home with my dog who was stung by bees, and he had an allergic reaction, and I had to take care of him. I took him to the vet and tried to relax him and keep him safe as much as I could. And I thought that it would be a good idea to share this story with the children, because it is a story about illness, but it didn't happen to me personally. It happened to my dog. And so there is an opportunity there to utilize the importance of looking after animals as well as looking after humans. In the story, the fictional space is a cherry farm where we meet grandfather. We also play with the bees and the birds, and we enjoy the sunshine, and the cherry blossoms bloom in spring and they are breathtaking. And when the wind blows, the petals dance like ballerinas in the sky. The fictional time is any time in the story. It could be in the morning or in the afternoon, but it certainly is not the real time where we are in the hospital. It's somewhere else at another time. We also visit in our imagination the beach, so the children have an opportunity to recall experiences when they go on holiday with their families, and play with the sand and their pets, and collect pebbles and build castles and bring beautiful memories back to them to normalize their hospital experience. If we zoom in more carefully into the story, we could see how we tried to create multiple layers of sufficient emotional protection for the hospitalized children in drama. And there are 4 layers. The first is the fictional context, the play frame. We aimed to help the child agree to the dramatic convention as they do in their play. So when the performer goes in, they introduce themselves with their real name, saying that my name, for example, is Mary, and I'm a storyteller. I'm here to tell you a story. Are you happy for me to sit by your bed and say a story? And once that is agreed with the child, then before the story begins, the storyteller uses a prop. It could be a shawl, it could be a pair of glasses, something to identify that this person is now in character, in role. So we frame it within drama. And once the character is ready to begin, then the story begins. And both the child and the person are in the story together. The second layer of protection is aimed to be created by using puppets. Puppet as a mediator between the storyteller and the child. We aimed to help the child engage with drama through those puppets. The puppet and the child communicate directly, and through the puppet, the child and the performer can communicate indirectly. And sometimes children brought their own dolls and toys and soft toys and teddies in the story. So we had this beautiful image of the child with the performer and their toys in the middle. The third layer of protection is aimed to be achieved by using a dreams convention. We aimed to help the child develop empathy and resilience in difficulty within dreams as a safety net. Because things can happen in dreams, good and bad things, but there is no judgment, and there is always a reassurance when we wake up that it was just a dream. And the fourth layer we created by using the invisible imaginary friend dog that becomes ill. So we aimed to explore how an invisible character could play the role of illness in the story. We aimed to empower the child to use their imagination in creating the dog. This in turn allows the child to modify their level of distress as a response to the ill dog, more so than with visual stimuli, as there is an added element of control. The story takes place within a fictional bubble. Performing in hospitals, we need to remember, is not an easy thing to do. The space is confined. You can see our beautiful performer here with the child and the puppet in between. The performance is extremely intimate. The actor establishes the fictional bubble, trying to be aware of the clinical surroundings and responsive to the patient at the same time. So what happens is that this imaginary bubble is an elastic one, and there is a lot of plasticity to it. So the character, the performer, and the child can at the same time be in the story and enjoy the storytelling, and also check outside the story bubble and see what's happening in the hospital environment. At the same time, if there are any disturbances happening, if there is a nurse passing by or a doctor coming in or a visitor coming to on the ward, then those distractions do not ruin the fictional. Because of that elasticity, we can be in and out, be aware of what's happening in two parallel worlds, because fiction is in dialogue with reality. The dramatic framing and emotional protection of the child is really important, because by doing that, we offer the children opportunities to be in the story, enjoy their time, but at the same time be present in their illness. So sometimes I hear people saying that performing bedside creates an escape. Teachers replied that it does create an escape for the children from what they experience in illness. And this may be true, but at the same time, I believe that what we achieve to do in drama is that we create the right conditions for the child to accept and embrace their illness and be who they are. Let them be in illness and deal with it within the protection of fiction. So the 5 themes that I came up with from the analysis of the teacher's response are these. The first theme is the improved communication, and the learning is highlighted in yellow. Building bridges of communication with children in hospital can help them develop trust with adults and talk to them about how they feel, explain to them if there is a physical pain, where it is located, how they can describe it, and what it is that really upsets them or makes them feel happy or makes them feel that pain. It's important to find ways to communicate, to let the children communicate that pain, because it's difficult for them to do it. And because of that difficulty, we find also a difficulty to assess their pain properly and help them manage their pain. The second theme is expression of emotions. Teachers see the project through educational filters, gaining insight into their teaching because they can see different aspects of the children's personalities. Children sometimes are too scared to trust an adult and say how they feel. It seems that this project enabled children to share their emotions. The third finding is how the children engage with learning intuition during their hospitalization. And I think this is a particularly interesting one because, to my knowledge, it's the first time that applied participatory theatre has been a tool in research in order to evaluate children's engagement with learning when they are in hospital. Sometimes it is alarming that children are left behind in their learning because that also causes anxiety and it affects the ways they go back to normality and back to school. The fourth finding is in relation to increased enjoyment and pain management. Teachers suggest that potentially bedside theatre could assist pain assessment and management. And I think that needs to be further investigated in a multidisciplinary study with nursing and clinical staff being involved. Definitely psychologists need to be on the board and artists with an expertise in participatory drama in healthcare. And the final theme is calmness and relaxation. Relaxation in pediatrics can be an extremely useful coping technique, and it seems that the use of puppets, the use of singing, the use of music, the intimate performance, the properties, all, you know, the portable trees, everything we brought on the ward to help the child relax and enjoy themselves worked well. Some concluding thoughts, you can see them highlighted in blue. Participatory drama can help children engage with language learning and do more homework. Puppetry in particular can create a sense of care, well-being and comfort in illness that relaxes children and normalizes their experiences. The use of fiction could create and support emotional safety and encourage hospitalized children to express their emotional needs. And the final concluding thought is about the role of artists in healthcare and how they can support children who need strategies to manage clinical pre- and post-operative stress. The paper I presented to you at a glance today is published in the Research in Drama Education journal. It's open access for those of you who would like to visit the link and watch it and read it. And thank you very much for listening. This is the end of my presentation. And now I would like to invite the dear colleague, Dr. Sidney O'Donnell, who is Associate Professor at the University of Utah in the United States, to start the discussion of my paper. Hello, Sidney, welcome.
Thank you so much for having me, Persephone. It's a delight and an honor to be able to join you today. Yeah, yes, where would you like to start with our discussion? I have so many responses. I mean, I do think that it's important to underscore the originality of what you've done in this particular paper with regard to bringing forward the importance and the important potential of theater and hospital to support children's learning. As you say, I haven't seen any other studies of this kind that suggest that. So I think that's incredibly important for the field and for literature, and to follow on with additional studies, because it is incredibly important for those children who are in hospital for extended stays, not to fall behind, as we have, seen, I think, over the past 2 years now, with so many children being not in school physically. And so there's a lot of talk in the United States anyway of learning loss that's occurred. And so I think many people who maybe were not previously sort of alert to this type of loss that can occur when our children don't actually get to be in school with other children, are perhaps a little bit more alert to it and to the importance of it. So that's wonderful.
Thank you, Sidney. Your expertise in drama and theatre is particularly important to this discussion, but your role as a mother also facilitates
yes,
the discussion.
Spent a little bit of time together.
It takes it at a higher level. So there are many concepts and possible ideas in the paper that we could follow and discuss. There's a range of topics such as the space and how we use the space, the aesthetic distance and what happens, the transition from the real to the non-real that is believed as if it was real within fiction. And I hope that I haven't just confused all our friends who are attending and have a different background other than theatrical. Also, the shift of the child's identity from a passive patient to a lively and more creative patient. So I don't know. I mean,
let's start with that one, because I think that one is such a, well, I mean, I love that idea, and I think you see it in other arts and health engagements with other populations as well as a really important one, especially as relates to vulnerable populations and identities. Yeah, I don't think that we can underestimate the power of the moment when in the intervention that you created and devised with the storytellers entering the child's space and inviting them to engage, but not requiring them to engage. That cannot be underestimated. I think the importance just of that little gesture in a hospital setting for a child who has very little agency and is there, you know, being poked and prodded and grown-ups telling them what they have to do, and you have to have this test and take this medicine and all sorts of things. And then to have an adult walk into the space and say, would you like to join me in a story, immediately alters the child's identity in that moment and invites them to be active participants who can say no. And the refusal, the ability to say no, I think is so important in the setting of the hospital for a child. And that sets the tone for the whole experience and invites them to be an active participant in what they're doing. I don't know if you want to say anything more about that particular bit of the intervention that you've created, and I know you've done this with other ones as well. That moment to me is incredibly important.
Yes, thank you, Sidney. Absolutely. I mean, it's all about the invitation of participation. It needs to be so gentle and so sensitive. I remember in another project, there were two performers who came bedside, and the way they approached the child was by saying, it's pouring raining outside, we're all wet. Is it okay to sit down and dry off? You know, so they came in a vulnerable state, saying that we are in need, you are the child, you have more power because you are dry and we are wet, you know. So it's the shift of the identity of the person who is in need, the vulnerable one. And so can you please help us? So we're not here to help you. We don't enter the hospitals as, you know, as saviors or as therapists or as evangelists. You know, we are just artists, and we use the medium of art to create those conditions that could potentially enable the child to have a better time when they are in hospital. And we need to remember that the space around the bed is not just the physical space, but also a replica of their emotional space. So how do we intrude? We also need to remember that those children, some of them spend more time in hospital than in their own bedrooms. And we visit them in their bedrooms, in their very private space. They are wearing their pajamas and they're not looking great because they are, you know, in a hospital and they've been through a lot. And although there are fantastic teams of people who are there to support them and help them with their health conditions, it's not the best of their times when they're in hospital. So how do we intervene and how do we enter their worlds is something that we need to be very attentive and very careful with. And from the artist's point of view, I think it's extremely challenging because there is no such training for artists how to do it. So I had to work very closely with my team to train them and prepare them and explain it to them and rehearse it with them and then brief them. And after the interventions, I had to debrief them. So it's a lot of work that needs to take place, and there is a gap in training, I think, that needs to be filled in so that we go in with respect and we go in as professionals and we learn how to create those professional boundaries in order to protect our emotions, because there is a lot of synergy of emotions between the child and the performers. And that needs to happen in a way that nobody's exposed to any potential, harm. No one is upset, no one is overwhelmed with emotions. And that is why I kind of tried to emphasize the importance of framing it all in drama. Yeah. I don't know if you want to reflect on that.
Yeah, I think that's another really important point, is the framing that you're talking about. In some discussions, and I'm going to use a theater term, and I'll try to unpack it a little bit, is the idea of aesthetic distance. So in theater and drama, not just in hospital bedside work, but in any theater or dramatic storytelling, we're dealing with emotional material quite frequently, as an audience, but also as performers and creators. But it's emotional material that's at a little bit of a distance from ourselves, because there is this fictional frame. I'm playing a character, I am not myself anymore. And so that is what we call aesthetic distance, where we're using the artwork and kind of putting the emotion that could be quite powerful and upsetting, right, in real life, and we're putting it in this kind of safe bubble of the fiction, the dramatic fiction. And so what I think is so clever about this script that you're talking about in this particular paper, where you have the dog that has been stung by bees and is not well, so you have kind of multiple layers of fiction that you've created around the illness narrative, so that the child who is, ill themselves, you're not coming in and saying, so, Joey, how are you feeling today? You're really sick, and let's talk about all of your feelings and emotions, right? Which for children, they're not going to typically engage in that kind of conversation, but they can engage with those feelings and ideas through a dramatic story. And they may, who knows if, especially a very young child, like a 4-year-old, will necessarily sort of realize that. But if they get to think about illness in terms of, oh, there's a dog and the dog has been is stung by bees, and then I get to care for the dog, this imaginary dog, which isn't even physically present, right? There's not a puppet, which I think is a very interesting and clearly a deliberate choice that you've made in terms of the aesthetics, is you haven't brought in a dog puppet that looks like it's been injured in some way. It's all in the mind of the child and the storyteller, rather than an actual object. So that creates that other layer that you were talking about of kind of protection, and the ability for the child to project feelings about illness, feelings about their own illness potentially on that story, and yet they are the caregiver in that story, right? They're the ones who get to offer care, offer advice to the other character about how to care for the dog that's been hurt and is not well. So I think that is another element that that your work has really emphasizes, and is really clear that that it's necessary to create that that space between the child or whoever it is that's engaging with this type of material and the story that could be a little close to home.
Yeah, that's a really good point, actually. And if we read the literature, there is a lot that's been said about the language of pain and how the adults can use metaphors to describe their pain, but younger children under the age of 8 or 9 find it extremely difficult to use metaphors and symbolize pain. So it can be very raw material, if you like, and there is a great responsibility how to handle this material. So children may have some words to describe how they feel, but not always, not all the children do. And I think what this project aimed to do was also to give them some vocabulary to use if they want, when they need it.
Yeah.
So there were some quotes from the story. Sam, the little girl, was comforting her dog, saying, "It's okay to be scared. It's okay to be scared." Or, "I didn't know that dogs could cry, but it's okay to cry." You know, and because children have to play the role of the good patient.
Yeah.
And sometimes we as adults ask them too much, not to cry, not to resist taking their medication, be patient, be good, do what we ask them to do. It's all for their own good, but it's chosen by us, and they don't necessarily always understand the whys. So when they feel bad because they are scared or because they cry, they need some vocabulary to say that it's okay to be scared, it's okay to cry. There's nothing wrong about it. So that's another aspect of the story, what we tried to achieve. And the teachers reported, I didn't have the time to go through all the quotes, but this is going to be recorded for those who would like to visit the link that will be available after this webinar. And you could then read the quotes, what the teachers said. They said that loads of the children used vocabulary from the story in their follow-up sessions. So how the story worked for the teachers and the children regarding the learning and the hospital tuition, how it engaged their homework was by following up the story in sessions on a different day. So the hospital teacher, together with the child, sometimes with the parent or carer or siblings participating, recalled the memories of the theatrical experience. The vocabulary, the moments, what happened, the storyline, the characters, what they were wearing, what they were doing, how did they feel? And they used that story, let's say, as a stimulus, as a starting point to develop their vocabulary, their written speech, their oral speech, to engage with learning without even knowing it, that they were doing homework. For those of the attendees who are outside the UK, the Key Stage 1 and Key Stage 2 tasks of literacy in the national curriculum in this country define some targets that the teachers wanted to achieve with the children. For example, communicating with unfamiliar adults, talking with others and sharing stories, using vocabulary, using their imagination, using full sentences, being creative, being imaginative, writing stories, using their own words to describe how they feel. These are all embedded in the story. So yeah, I think it's really important to remember that. And actually something that I want to stress here. Theatre can go into hospitals and hospices to do many good things, to entertain those children, to help them relax, to create opportunities for them to show how they feel and share their emotional needs, to help them engage with learning and so on. But first of all, and the main task for me, is to create an artistic product of high quality, so that we don't offer children something that is created in a rush, without thinking behind it, without special care, and without artistry. Because then we undermine them as spectators. And to us, they are not patients as they are for the nurses. They are not pupils as they are for the hospital teachers. To us, these children are audiences. And that helps the child and the performer to create and maintain that professional relationship between the audience and the creator. I don't know what you think about it, about the importance of the quality of the performance, Sidney.
Oh, I absolutely agree with you 125%. I mean, it's so important, the quality of the artistic, whatever the artistic engagement is, if it's drama, if it's visual arts, if it's music, any of those, the people, the professionals involved in creating the work should be professionals. They should be people who really are masters at their craft, and then also have that understanding of whatever the setting is in which the work is being done. So if it is a children's hospital setting, obviously you need that other expertise, either directly through the artists themselves, or through partnerships between the artists and professionals in the hospital setting. And really, you probably need that anyway. But I don't think that we can, you can't do this work without having a really high quality product, I guess, if you want to put it in those terms. It's as you say, I think it's a matter of respect for our audiences, but also I think that the outcomes that you see in the work that you've done so far, Persephone, over many years now, is not unrelated to the quality of the work that's being done from an artistic point of view. You can't really separate those two. I think that sometimes you'll see engagements in healthcare settings with the arts that are unsuccessful, and often that can be put down to the fact that the professionals were not engaged. They weren't engaged early in a really thoughtful way, in the development of whatever that intervention was, and so it doesn't get done. It doesn't result in a high quality outcome if you're not engaging the right people. And professional artists, they know what they're doing. So yeah, I can't agree with you more about that, Persephone. Mm-hmm.
Wonderful, thank you. I know that we can keep on talking about this, and it's a wonderful discussion. I really enjoy it. I hope our attendees all enjoy it as much as we do. Now, the wonderful backstage team of producers alerted me to time restrictions, and I think it's about time to look into some of the questions. Do we have questions, Di and Charlotte?
Yeah, we've got quite a few questions. So the first one is from Stephen Clift, and he said that he was struck by the repeated reference to stress and relaxation, suggesting to him the importance of autonomic tone for the children. And he wondered if you'd considered ways in which sympathetic and parasympathetic balance could be assessed.
Thank you, Stephen. For everyone's information, our lovely Professor Emeritus Stephen Clift is the previous director of the Sidney de Haan Research Centre and the one who found it. So hello, Stephen, and thank you for all the work that you put into this centre to be what it is today. And thank you for your question. I think we need to be definitely aware of the possibilities of this type of work and different ways of assessment. And I would really like to add a fifth avenue to the assessment of similar projects. That would be from psychologists and from other multidisciplinary teams, as I mentioned earlier, so that we can access other aspects of the impact of such work on children's stress and how they experience pre- and post-operative anxiety. I don't know if Sidney would like to add anything to this.
Yeah, I know there are some studies that have been done both in the UK and the US looking at different sort of markers of stress and the impact of arts engagements on the participants in those, looking at stress hormones, looking at heart rate, use of or administration of pain medications. You know, the one sort of hesitation, right, that I think about, particularly for children in hospital, is not wanting to add another thing that needs to be done to them. If it's not already part of you know, measuring how the child is doing, I would be, you know, the ethics of adding more stuff to measure is a little troubling to me, but I imagine that there have got to be ways to track the stress response and relaxation responses that are already kind of built into the ways in which we follow children in hospital in terms of looking at their heart rates and blood pressure and that sort of thing. Those things that we, you know, folks go in and check every couple of hours in some cases, or more frequently in other cases. So that would be, those are the things that I've seen in the literature, and that, you know, could be added potentially to what you're doing in ways that maybe aren't terribly invasive for the children involved in studies of this kind.
Yes, thank you, Sidney. It is possible, and now I remember that I took some measurements of this kind, more rigorous as the medical world calls them, because they're more interested in such facts when they measure and when they evaluate the importance of participatory arts for health and well-being. It was a project that took place at Birmingham Children's Hospital about 10 years ago, and I had all the ethical protocols in place to do it. So the measurements were taken by the nurses, and those included the cardiac pulse of the children pre, during and after the intervention, and they also made notes about the children's quality of sleep. If there were children who were uneasy and upset, they asked us as performers to go in and perform just before their night's sleep to see if that would improve their sleep, and they provided us with those notes. And I'm sure that in close collaboration with the nursing staff, those measurements can happen. At the same time, I still believe that the ways we see the arts when they enter the clinical culture can further develop, because sometimes we see the arts as entertainment only, and sometimes we try to convince ourselves and others, possibly potential funders most often, to see the arts as a tool to improve the health of those children and young people in hospitals. And I'm sure that combinations of the two can be possible. And for that, multidisciplinary and cross-disciplinary strong research teams can come together so that one does not work against the other, we need to find ways to collaborate and appreciate data, anecdotal data, clinical data, artistic data. All data is valuable. It's how we interpret it and what we do with it. Is there another question for us, Charlotte?
There's a question from Eleni Hatzidimitriadou, who has asked, can you elaborate on the interaction with healthcare professionals during the research activities? What are the power dynamics, as clearly your method is changing the children's position from being patients to being active recipients of care?
Thank you, Eleni, for this wonderful question. Eleni oversees the Sidney de Haan Research Centre at the Faculty of Medicine, Health and Social Care at Canterbury Christchurch University. I think from my experience, we've worked really well with healthcare professionals, with nurses, and with doctors who sometimes happen to be there when we start an intervention, or they come to visit for a treatment during the show. It's important to be clear about the roles, who does what, because we are all experts in what we do. So the health professionals don't intervene in the performance elements, and we as artists would never like to, play the role of the health professional. A collaboration between us all is important, and we need to understand that, because we are all on the same boat, and what we do, each of us, from where we are standing and from what we know, is to benefit that child in that moment. Nurses have been extremely helpful. Sometimes they sit to watch the performance with the child. Sometimes they wait until the performance ends before they take the blood pressure or before give a medication, if it's only a 2 or 3 minutes delay. If they have to intervene, if they have to stop the performance, then it's up to the artist to integrate that disruption in the show, make it look like a part of the performance. So the actor responds to the nurse in role, as if this is something that happens within the story. And we've had some wonderful nurses who reacted and responded to the puppets. So it becomes a social event. And that's the beauty of it. And I think it happens like that because we all want the best for that child. And from experiences of working with nurses and having some informal discussions after those performances, I can observe that artists, not only performers, are actors and actresses, but also musicians, singers, and even magicians that go on the words. They add something to the nurses' lives and professional experiences. Somehow we create better conditions for them as well as for that child. Nurses seem to enjoy and they participate in what we do. And they've also been extremely collaborative when we ask them to collect data for us, as I mentioned earlier. Now, one of the areas that I think we need to improve is the training of nurses in conjunction with the training of artists, and therefore joined efforts to produce courses for nurses and artists on arts and health are important. In order to marriage the two cultures, in order to explore ways of both artists and nurses working together when they are in the same place at the same time, in order to broaden their understanding about the importance of imagination and creativity, in order to help nurses understand how what we do as artists with the children could actually help them understand the children better as their own patients, how to support their pain management better, how to follow up our interventions, as the teachers do for educational purposes. Nurses could follow up artistic interventions for nursing purposes. Sidney, would you like to contribute to this discussion with your own view?
I mean, my views, I guess, at this point are really supporting and underscoring everything that you've said already, Persephone, and I think it goes back to the sort of the question of professionalism and quality, and having an understanding of everyone on a team, including the artists and the health care staff, the nurses, physicians, medical assistants, all of that, that everybody in that space is a professional with training in a particular domain, and there has to be a certain level of trust that the people who are in that space together have an understanding of what the goal is, right? Which in this case is the care of the children and ensuring that the children are treated with respect, that their health is being considered, that their well-being is being considered, all of these things. So yeah, I mean, basically I would just re-emphasize everything you've said, and just add that this connects back to that professionalism conversation. And I think, the UK has a more developed arts and health system, I think, generally than the United States does. We're increasing our understanding of arts and health over here, but I would say that the idea that the artists who enter hospital spaces are professionals is not always widely understood by our healthcare colleagues quite yet. That's not in all cases, but where it's new, it's not always well understood. So sometimes there's a little bit more education that needs to happen on teams in the US than perhaps in some settings in the UK where it's better established.
Well, they may be better established over here, but there is still a big discussion going on about the accreditation of professional artists in healthcare. And I was attending a conference a while ago, and I suggested that this accreditation should take place, and there were conflicting responses. So some artists, especially those with a long experience in the industry, they were not extremely positive about the accreditation, although they had a lot of experience. And the youngest ones that graduate from universities and drama schools with some specialism in health and well-being, those were very keen on the accreditation. So until we resolve this, there is a lot to discuss. We're still not quite there as yet, but it's an important conversation.
Yeah.
We have time for another question.
Yeah, we've got a question asking, do you have any plans of widening the uptake of this intervention in the NHS, and how might that work?
There are plans to expand those interventions in more than one hospitals. It's all down to finding the right collaborators and the right funding. And I'm optimistic that this can happen. It requires a lot of coordination because multiple sites request multiple protocols, multiple communications with R&Ds and with the teams in different hospitals. But I'm so passionate and so convinced that the arts can make a difference to children's and young people's lives when they are hospitalized, that I think that nothing can stop me and colleagues with similar interests to multiply those interventions patients and find the way to outreach as many children as possible. And I believe that we have time for one more question.
Yes, there's a question touching on something you mentioned a few moments ago. The question is, my understanding is that none of the artists in healthcare involved in this intervention are credentialed drama therapists. How has their training included clear awareness of an appropriate scope of practice for them, i.e. a scope of practice that doesn't cross into delivery of therapy for which the artists are not trained?
Thank you for the question. I think it's a question that can start a huge discussion that could possibly require another webinar. Clearly, artists in healthcare are not therapists. In this country, therapists need to attend and graduate from a master's on either drama therapy or dance therapy or art therapy, music therapy, etc. We don't claim therapeutic results. We don't make promises for therapeutic results, and definitely we have no therapeutic intentions. There is a grey zone between what is therapy and what is not in healthcare environments. And people often confuse us with therapists because we work with patients in hospitals and we use the art form as a medium. However, we don't use the arts as a tool to resolve any problems. There may be cases when emotions are shared that the interventions could go and sail closely to areas that drama therapists would be the ideal people to deal with. And it's part of the training I personally gave to the team of professional actors who performed for me in hospitals to make them aware of those boundaries. And actors need those boundaries to protect themselves as well as the children. So I think that there is a lot to be learned from collaborations between therapists and artists who are not therapists. So, for example, we work sometimes together with play specialists and play therapists in hospitals who could follow up the work that we do, or they could give us some information about children, not confidential information, of course, just to make us aware of what we need to be aware of when we work with children on some of the hospital wards. For sure, I think there needs to be a distinction between the role of the arts in healthcare and therapies. Sidney, would you like to reflect?
Sure. Yeah, this is an enormously important issue. Yes, often artists in healthcare are confused with arts therapists of various kinds. In the US, there's a growing movement, I would say, and it's not accreditation yet, but at least a more formalized curriculum to train artists who are working in healthcare settings to define their scope of practice, right? So that they understand this distinction that Persephone outlined between the artist working in a healthcare setting of some kind and the arts therapist, two totally different scopes of practice, which sometimes there is that overlap. One of the things that artists here who are being trained and learning to work in healthcare settings now are very clearly being trained to do is to understand if there is a need that they run across when doing an arts intervention with someone, they will understand, you know, a therapist should probably follow up with this person. So University of Florida, for example, their Center for Arts and Medicine, they have a real close relationship between their artists and residents and the therapists who work in the hospital setting, so that they're in conversation with one another. And if there's a sense that something has been triggered during a session where a musician is playing for a patient and something is triggered in that patient, the artist will then go to the therapeutic team and say, this person needs something, follow up with them. It's extremely important for artists to understand their scope of practice and to understand when there may be a need for additional support, that because of something that maybe the artwork touched off for a participant or for an audience member.
Yes, definitely. And we also need to acknowledge that the artist who works in healthcare needs training, not only on their professional skills, but also on their emotional competencies. And I published 2 articles in the Applied Theatre Journal, one in 2018, one in 2020, on this topic, the professional skills and emotional needs and competencies of actors and other artists who work in healthcare. And what I argue there is that artists and psychologists need to work together to set up programs of study for that purpose. It's 5 minutes past 3 o'clock, and I would like to thank everyone for attending, for participating, for your time and for your questions. I would like to thank the wonderful team of producers, Di White, Charlotte Granger and Lars Harald Maigero, and my lovely colleagues from Sidney de Haan. I cannot thank enough Sidney Chica O'Donnell, Associate Professor at the University of Utah in the States, who joined me today. Thank you so much, Sidney, for your input. And may I invite you all to the next webinar that we are hosting at the Sidney de Haan Research Center. It takes place on the 22nd of February at 2 o'clock GMT. The title is The Galaxy Choir, Exploring the Impact of a Choir for Adults with a Learning Disability, Promising Findings and Ways Forward. And we have 3 fantastic speakers, Esther Coring, Julia Moore and Jacqueline Talent, members of staff at the Sidney de Haan Research Center, and a designated academic, Daniel Marsden, who will join them to discuss their fantastic work. There are another 2 webinars coming up about applied puppetry in healthcare and about the role of participatory arts and VR technologies in palliative care in Australia. Those webinars will take place in March and in June. So you're all very welcome to be in touch with us, visit our website, tweet, retweet, look at our Facebook page, and feel free to contact us if you have any further questions. The chat will be open for you for another 10 minutes if you want to send questions through the Q&A box. The live event will end and I will try to answer some of your questions on the Q&A box. Thank you again so much for being with us today, and I hope to see you again soon. Bye for me. Thank you. Bye.